Hello, my name is Rebecca Ramirez McKinley. I am currently a doctoral candidate in the Doctor of Athletic Training program at AT University, and this is my applied research project, the treatment of sports-related concussion with comorbid whiplash, a systematic review. It was done in conjunction with Dr. McLeod, who helped to guide this project, and I want to start off by thanking her for all of her help and guidance in completing this project. So some of my background, I have an extensive background in manual therapy, especially in treating the neck and back and pelvic areas. I started to see a pattern of concussion with lingering symptoms. My student athletes were complaining of neck pain or tightness or stiffness and a headache more than 7 days post-injury. So I began treating these injuries with manual therapy and evaluating the associated neck pain, and I've had positive results with it. So I wanted to look at the literature surrounding the treatment of these injuries together. So concussions have most recently been defined as complex physiological process affecting the brain induced by traumatic biomechanical forces. Concussions are classified as mild traumatic brain injuries that may lead to long-term sequelae if they are not evaluated and managed properly. Mechanism of injury for concussion is caused by either a direct blow to the head, face, neck, or indirectly through impacts elsewhere on the body with impulsive forces transmitted to the head. Similarly, cervical spine injuries, such as whiplash-associated disorders, may result from the application of these forces to the neck. Concussion and cervical spine injuries may occur simultaneously, with symptoms from whiplash-associated disorder overlapping with concussion symptomology, making it difficult for the clinician to discern between the two. So this led to our clinical question of what are the treatment methods for sports-related concussion and comorbid whiplash, both in acute and post-concussion syndrome in athletes. So treatment methods between concussions and whiplash-associated disorder vary greatly. The cornerstone of concussion treatment has been cognitive and physical rest. Recently, strict rest has been shown to be detrimental to potential comorbidities, and it may delay recovery and have a negative impact on the patient's mental health, leading for the need of judicious balance between rest and the resumption of activities to be considered. Conversely, whiplash-associated disorder is treated using a multimodal approach, including postural training, eye fixation exercises, manual treatment, and psychological support, which may be more beneficial than physical therapy. It's recently been recommended by Cheever et al. That the acute treatment of the identified impairments be utilized in order to restore the various systems individually and collectively. Evidence has also shown that the cervical spine plays an important role in patients with concussion who have benefited from combined cervical and vestibular rehabilitation, thereby creating a need for further research in this area. While many studies have been conducted on concussion and whiplash injuries separately, there are very few studies that investigate these injuries in unison. Athletes are at an increased risk for these comorbidities, and looking at this relationship is important due to the increased risk for injury incurred within this population. Few studies have looked into the relationship between whiplash and concussive episodes in athletics, and whiplash-associated disorders and concussions can be very similar, making it difficult to distinguish between the two injuries. So this systematic review was conducted in accordance with the PRISMA guidelines, utilizing the PRISMA checklist. So after an extensive literature search through 6 databases, we've compiled 1,770 articles. After removing duplicates and those articles which did not meet our inclusion criteria, we ended up with 38 articles. We had excluded an additional 26 after the initial full text review. We then did a manual search, yielding 7 more articles, and we had 19 for a full review, and we ended up with 5 studies being included. So our inclusion criteria were that the studies had to have diagnosed concussive episodes, there had to be a diagnosis of whiplash-associated disorder, participants had to have participated in athletics, publications had to be in English, they had to be original research, randomized control trials, case studies, and cohort studies. The exclusion criteria is motor vehicle crash. Whiplash diagnosed after 3 months, other brain injuries, and anything that wasn't original research, randomized control trials, case studies, and cohort studies. So we ended up with 5 studies. One, which was a randomized control trial. 2, which were case series. 1 was a retrospective analysis, and 1 was a retrospective cohort study. All of these studies included the sports-related concussion component with a neck injury whiplash-associated disorder. So while the majority of concussions were related to athletic participation, Horstman et al. Contained 2 patients who were athletes but sustained concussions in a motor vehicle accident, and Hughes and Tober et al. Contained 2 patients who also suffered from MBAs. We could not exclude these studies because in Horstman et al., everybody was an athlete, even though the concussive episodes did not happen from an MBA. And in Hughes and Tober et al., we could not isolate the data from the MBAs, so we could not remove that data in order to just look at the athletic participation, but that's okay. So in total, the studies contained 112 subjects ranging in age from 12 to 30 years old. Only 11 patients were lost to follow-up in the study conducted by Kennedy et al., with the rest completing the prescribed treatment. All of the studies included some sort of physical therapy component that contained a cervical component, with treatment including vestibular and/or cervical spine rehabilitation, as well as other treatments such as postural education, manual therapy, acupuncture, and cardiovascular training. The various treatments for cervical spine included joint and soft tissue mobilization, occipital release, strength training, flexibility programs, and postural re-education. However, not all of these studies specified which treatments were administered for the cervical spine, therefore specific details regarding the nature of each treatment are not known. In the only randomized control trial that met the inclusion criteria, both control group and the treatment group received treatment that included non-provocative range of motion exercises, stretching, and postural education, with the treatment group receiving cervical spine and vestibular rehabilitation. This is important as, unlike the other studies included, the examiners were able to compare treatment protocols within the study. Treatment procedures varied between all of the studies, with all containing cervical rehabilitation component, but not all containing manual therapy component. Of the studies included, 4 utilized cervical spine rehabilitation, 3 utilized some form of manual therapy, vestibular rehabilitation and flexibility programs, 2 used postural re-education, 2 utilized cardiovascular training, and 1 included acupuncture. The frequency of treatments varied by study, and there was no consistent treatment protocol. So the outcomes of the studies reported significant improvement in all outcomes measures with those who underwent rehabilitation programs. Outcomes measures across the study included the post-concussion symptom scale, a visual analog scale, the neck disability index, and the dizziness handicap inventory. Clinician-based measures included the BEST test. So, with that, post-concussion symptom scales, all of the patients had significant improvements, which means that they had lower scores. Visual analog scores improved 67.5% to 100%. Neck disability index scores improved 20 to 100%, and the dizziness handicap inventory scores improved 22.2 to 100%. Schneider et al. Found that those who received additional vestibular and cervical spine rehabilitation were 3.91 times more likely to return to athletic participation within 8 weeks of treatment initiation. So the implication of this is that the potential benefit of treating cervical spine injuries with concussion. Given that all of these studies showed positive outcomes, they all concluded that through the use of both clinician and patient-based measures, that cervical spine rehabilitation facilitates and is beneficial to those who suffer from neck injury with sports-related concussion. So the systematic review evaluated the various treatment options for comorbid whiplash with sports-related concussion. While other systematic reviews have looked at concussion with general neck injury, there was only one study that other systematic review that we could find that looked specifically at whiplash-associated disorder. This was surprising given that in a study conducted by Guskowitz et al., 31% of patients reported neck pain immediately post-injury. 33% of patients reported neck pain within 24 hours of injury. However, finding studies that looked at comorbid whiplash and sports-related concussion proved extremely difficult. With the current lack of literature surrounding comorbid whiplash and sports-related concussion, there are no treatment guidelines that specifically address these injuries. Recommendation for treatment of sports-related concussion includes rest, with a gradual return to activity, but whiplash is one of movement, rehabilitative exercise, and return to daily activities. With these conflicting treatments, it can be difficult to determine how and when to treat whiplash associated disorders that occur with concussion, and it is as rest can be detrimental to those recovering from whiplash associated disorder. The results of this systematic review show that the treatment of the whiplash component provides positive outcomes, especially in those with post-concussion syndrome. Some consideration for clinicians that have come out of this study is that clinicians, when they are looking to treat the whiplash component of the comorbid whiplash with concussion, is time since injury, symptomology, potential for symptom exacerbation, potentially to begin with manual therapy. These are low cost, low risk treatments that are readily available in any clinic, and to look to use an appropriate multimodal approach to treat the concussion and the whiplash injury. So from this study, we have some recommendations for future research. With a lack of level 1 and 2 evidence regarding the treatment of comorbid whiplash with sports-related concussion, it is imperative that future research looks to establish first appropriate treatment guidelines for these comorbid injuries, and also to establish treatment guidelines for clinicians. The effectiveness of various treatments and the timelines in which it is safe to begin treatment need to be investigated and answered as well. Additionally, we need more randomized control trials to be conducted, as the body of evidence is primarily retrospective studies and case series, which are considered low levels of evidence. A strong need exists for higher level of evidence within the athletic population as well. So there were some limitations that occurred with this systematic review, including a lack of literature on comorbid whiplash and sports-related concussion, which made it really difficult to find enough evidence in order to conduct this review. Additionally, several articles were found regarding these conditions, but were not in English and had to be excluded from the systematic review. I believe they were in French. While the study looked primarily at sports-related concussion, 2 of the studies contain concussions related to motor vehicle accidents, and we couldn't exclude that data to look at only sports-related concussions. This posed difficulty of purely looking at the sports-related concussions. However, some of the patients were still athletes, still could provide valuable, and that can still provide valuable information. This is especially due to the lack of literature regarding sports-related concussion and whiplash-associated disorder, and there's not a strong body of high-level evidence, making it difficult to compare studies and outcome measures. I would like to thank you for viewing this video, and I would like to thank all of the staff at AT Still for their support in getting this project done and in guiding me through the research process. This was a very new and unique process, doing a systematic review, and I would like to thank them for their help and their understanding in getting me through the process. I'd also like to thank my family and my husband. Without them, I would not have gotten to this point. So again, thank you for viewing this project, and I hope you enjoyed it.